Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime using the chat pod located to the right of your webinar platform. You may also download a copy of today's presentation using the Files pod located directly below the chat pod. It is now my pleasure to turn the conference over to Chris Hunt. Please go ahead.
Thank you so much. Hi, everybody. Happy New Year and welcome to the January 2019 AHA Team Training Monthly Webinar. My name is Chris Hunt and I'm the Director of the AHA Team Training Program here at the AHA Center for Health Innovation. This month's webinar is going to be the what and why of TeamSTEPPS, a new way to look at the tools and concepts from our faculty at the University of Washington Team Training Center that we work with. Just a few rules of engagement for today. Audio for the webinar can be accessed in two ways. You can either listen through your phone, and if you do that, and it's probably the best sound, you're going to want to mute your computer speakers so that you don't get a weird echo effect. Or you could listen through your computer if you have a really solid internet connection. We're going to do a Q&A session at the end of the presentation, but please feel free to chat in those questions as we go in the chat pod that's on the right-hand side of the screen as you look at it. We're going to try to answer questions as we go. Any of them that we don't get to, we'll do a Q&A at the end of the session. And any of those that we don't get to, we'll make sure to answer you over email as time goes on. Some upcoming events for the AHA Team Training Program. The big one is the 2019 AHA Team Training National Conference. That's going to be in San Antonio, June 12th through 14th. Registration actually opens very soon. It opens January 15th. So next week, on January 15th, you'll be able to start registering for the conference. Event is a great event, a growing event that has individuals from really around the world who have submitted proposals that we're looking through right now, and we're going to have material that covers really everything that has to do with how you as a team can make your work better in your health system. So it's more than TeamSTEPPS, it's a wide variety of topics. So very excited to have registration opening for that soon and to see you in San Antonio in June. Our course schedule is also now posted for master training courses for TeamSTEPPS in 2019. That is going to, registration for those are going to be opening in late January. Some of our trainers are who our presenters are today from the University of Washington, so if you really love them, they're going to be doing a couple courses next year, along with all of our other great faculty around the country. Our next monthly webinar is February 13th, and it's Expanding the Team, Practical Uses of TeamSTEPPS for Non-Clinical Team Members. So whereas this webinar is going to be focusing on an innovative new way of thinking about TeamSTEPPS clinically, the next one kind of partners with it, and we'll be talking about how to think about using TeamSTEPPS with people that are outside of the normal clinical realm that you work with in your health system. If you ever have any questions for us, feel free to visit our website, aha.org/teamtraining, or drop us an email at teamtraining@aha.org. We also have dedicated phone lines, so feel free to give us a call at any time, and we'll get back to you as soon as possible. I'd like to welcome today's presenters, all three of them from the University of Washington, from the WISH Center, which is the WAMI Institute for Simulation in Healthcare. We have Ross Ermintrout, who is the Clinical Director of Team Performance, as well as Megan Sherman and Farah Leland, both Associate Directors at WISH. Three of them have been teaching TeamSTEPPS for many years and have really innovated in how to teach TeamSTEPPS, where to take it to the next level, and how to connect it into everything else you're doing so that it's really not another initiative, but part of the fabric of your daily life. So with that, I'm going to turn it over to the team.
Thanks, Chris, and hello, everyone, and welcome. First of all, I'm Ross Ermentrout, and I'm a nurse by background, and most of my career, my bedside career was critical care at Harborview Medical Center, which is part of the UW Medicine Health System. I worked in the burn center for about 10 years, and then the trauma ICU for about 9 or 10 years, and got involved in patient safety back in 2004, and was the patient safety officer at Harborview for about 10 years. And now my role is clinical director of team performance for UW Medicine. So we have 4 hospitals, over 200 clinics, and I cover those working on implementing TeamSTEPPS throughout our health system. I'm going to have Megan and Farah introduce themselves real quick.
Yeah, hi everyone. My name is Megan Sherman. As Chris said, I'm the Associate Director for Operations for the WISH program. Both Farah and I are non-clinical by background. My background's actually in education and human development. I've been teaching TeamSTEPPS for quite some time, and it's great to see some familiar faces or names, I guess, on the chat box. So welcome everyone. We hope you enjoy this.
And hi, I'm Farah Leland. I'm the other Associate Director of WISH. My background, like Megan said, is non-clinical. I come from a law background. And yeah, we're excited to be here. I see lots of names I recognize and quite a few people from the Pacific Northwest that I haven't met, but been looking forward to chatting further.
Yeah. Thanks, you guys. And just a quick shout out to our friends in Norway, Oddvig, Tori, and Randy. It's good to see you on, even though we know it's about 7 p.m. over there in Norway, and all our others from around the world that are attending. This morning or this afternoon or this evening, depending on where you are, our goal is to just kind of give you an overview of TeamSTEPPS, looking at some of the backgrounds. I think some people have more background in TeamSTEPPS than others. This will be somewhat basic, but we'll try to address some of the implementation parts of this as we go through this. We're going to describe the contributing factors to medical errors, discuss how implementing TeamSTEPPS in healthcare can lead to improved patient outcomes through better communication and teamwork. And then something we've spent a lot of energy on here at the UW is to break down these tools into 100, 200, and 300 level skills, and we'll get into that as we go. So if you hadn't heard of TeamSTEPPS before, here's exactly what it stands for. It's Team Strategies and Tools to Enhance Performance and Patient Safety. It originally came from the Department of Defense, and it's based on more than 30 years of research and evidence. And it's been shown to improve those attitudes, knowledge, and behavioral skills throughout. And some of you are probably familiar with Eduardo Salas, who did a meta-analysis that says you get this positive effect on team outcomes when you do some of this team training. Here is the official logo for TeamSTEPPS now that comes from the American Hospital Association. And you can see within the TeamSTEPPS framework, there's 4 major concepts. There's actually 5, team structure, but the 4 here are leading teams, situation monitoring, mutual support, and communication. Those 4 all have a set of tools and concepts within them to help us standardize and improve our teamwork and communication. And so here's a breakdown of the key concepts of TeamSTEPPS. Again, each section, each concept has some tools that we're going to introduce today that you can use to start working through implementation in your own healthcare system. So but why is this important? Well, a lot of you are probably familiar with this report that came out 19 years ago, going on 20 years now, in the Institute of Medicine that said almost 100,000 people die every year from preventable medical errors, and 72% of those are related to communication. So it's not because we were putting a central line in somebody and they had a pneumothorax from that and ended up having to have a chest tube and died. That's 28% of the time, and technical errors are going to occur, but 72% of the time, it's just that we didn't communicate well. We didn't function as a team. But we know that that data is pretty old, but 14 years after that, a couple articles came out, one in the Journal of Patient Safety, and John James, who's not even a clinical person, he's a PhD, an engineer PhD, whose son died in the hospital because of a communication breakdown. Well, he did a meta-analysis in 2013 and found that the rate is actually probably 200 to 400,000 people dying every year from preventable medical errors. And you know, you kind of go, well, we're going the wrong way here, but I don't know that that's necessarily true. I think we're just better at finding those preventable medical errors. But the key part of this is 70% of them were still related to communication. So we made no movement in that in 14 years. And several years ago now in BMJ, and you might have saw this as a big news story, preventable medical errors are the third leading cause of death in the United States behind heart disease and cancer. They said, Mark Rhea and Daniel said, the IOM was underestimated, John James probably overestimated, but they came up with a number of 251,000 people dying every year from preventable medical errors. And again, 70% of them are still related to communication. So clearly we have some opportunities related to that. One more statistic, and then we'll move on to some other things, but this came out in JAMA a couple years back now. In the United States, hospitals leave a foreign object in a patient 96 times a week, perform the wrong procedure on a patient 10 times a week, and operate on the wrong body part 20 times a week. So if you really think about that, that's 10 years after the Universal Protocol came out, and the timeout has been mandatory in all procedures, not just the operating room, but all procedures. So we have processes in place, but the culture is not necessarily set up. I may be in a room with somebody that the timeout needs to occur, but maybe I'm the new person in there and there's a very experienced long-term person in that room, and they just choose not to do the timeout, or they choose not to be engaged in the timeout. Our goal here is to figure out how do we empower that new person to speak up and say, hey, Megan, can we just stop a minute and make sure we're all engaged in this timeout? Because I think the timeout's occurring. It's just the quality of the timeout that kind of leads to these things. So within the TeamSTEPPS framework, our goal here is to try to move from a team of experts to an expert team. And I told you I worked in the trauma ICU for about 9 or 10 years, and I felt like I was an expert trauma nurse. I worked with expert trauma surgeons, expert pharmacists, expert social workers, but we didn't always function as an expert team. And there's a huge difference between those two, and that's what we're trying to do. We're trying to get that team of experts to work as an expert team. There's lots of evidence out there. I'm just going to throw 2 things up here, but there's plenty of resources. If you go to the AHA website and tap on resources, you can find all you want, multiple articles out there about teamwork and how it affects patient outcomes. But here's just a couple. Capella, they did a trauma resuscitation team implementation of TeamSTEPPS and did pre and post training reviews, and found that they improved across all teamwork skills: leadership, situation monitoring, mutual support, and communication. And they're able to decrease times, intubation, CT scanner, etc. And then Thomas and Gala from Northwell have done a lot of implementation in their system out there in New York, and they also did pre and post training results and showed significant improvement on their hospital safety cultures scores, feedback and communication about error, frequency of events reported, handoffs, transitions, and they've also showed a reduction of nosocomial infections, falls, birth trauma, and other incidents. So there is some data, and people are going to want that. They want to know if this works or not, and there's plenty out there. We know it's the right thing to do, but people still need to see the data. So as I mentioned up front, talked about the 100, 200, and 300 level skills, and this is where we've got the best success in implementing TeamSTEPPS throughout our health system. The 100 level, just like when you go to college, you take the 100 level course first, and then you go to the 200 level course and your 300 level course. We think those 100 level skills, especially those first 5, are individual skills that as soon as you're done with the training, people should be able to walk out of the room and be able to do, if they're not already doing it, use what we call closed loop communication for those first 4 tools, and Farrah's going to get into those in a minute. You don't have to wait until everybody goes through team training to start implementing those 100 level skills. As you move to 200, those require more of the team, and then when you get to the 300 level skills, that's where you start really getting into the culture change, and we're going to address these as we go through this webinar. So I'm going to hand this over to Farrah now.
So effective communication really needs to be complete. So making sure you have all the relevant information and not that excessive detail when you're communicating. And then clear, standard terminology, and minimize the use of acronyms. There's a lot of acronyms in healthcare. There's a lot of acronyms in TeamSTEPPS. But different acronyms across different specialties mean different things. So One example we have is we were working closely with our childbirth center here, and they had AMA on a number of different things during their simulations, and we were like, why do they have against medical advice on all these patients? And then we found out that it also actually means advanced maternal age. So within our healthcare system, within different surgical specialties, we have different use of acronyms. So making sure that you don't assume everybody knows the acronyms you're using. Be brief. So when it's really long, information gets lost. So make sure that you're concise. And then finally, be timely. Avoid those delays and have an opportunity to verify, validate, and acknowledge any information that you're giving. Okay, so here's an example. Here's an example of a acronym. I'm sure you guys are all laughing. I wish I could hear you. But what does IDK, LY, and TTYL mean? I don't know. Love you and talk to you later. Okay, I'll ask your sister. So she's responding but didn't quite get that. So avoid those use of acronyms, just another example. So closed-loop communication actually has kind of three components to it. It starts with the initiation of the message, and that can be done in two ways. It can be done with a request or a call-out. So a request is, you know, we always tell when we're teaching this that a request really needs to use the person's name, make eye contact, and then use point at them. And we did get we got some feedback that pointing was not going to go over well with if a cardiac surgeon did that from one of the organizations that we taught at. So we came up with the solution of doing the Disneyland point or gesture. They don't point a finger. They use a two-finger point or open-handed. So we like to use that. You can look it up online. It's a real thing, I promise. So, so when you're requesting, doing those three things, that does a couple things. It makes the person that you're giving the request to know that you're talking to them, and it also makes everybody else know that you're talking to them. When you don't do that, we call that the kind of the King County request when you don't direct it at somebody. I need a yank or a sucker. Well, we live in King County. That's why we call it the King County request. So either nobody's going to go get it or a bunch of people are going to go get it. If you don't direct the request, it makes it very hard for the communication to close that loop. And the second way to initiate the message is a call-out. A call-out is really that just calling out information so the whole team can get to that kind of shared mental model. They're on the same page. So that an example of that would be when you're working on a patient and you're just calling out their vital signs as things change. Many times people get task fixated, so they're not seeing all of things, and they can lose situational awareness. So a call-out is just making sure the whole team hears the information. Then we move to the cross-check. And the cross-check is really repeating back that information. So it could be, once it's initiated by the request or the call-out, either repeating back the request exactly as you hear it, or repeating the call-out so that the person knows that you heard it and it could start the loop as well. This is probably this is not a TeamSTEPPS specific tool. However, we feel it's really important, and and I'll talk about it in a couple of slides, about a specific situation that we feel the cross-check would have made a huge difference. So the cross-check is really repeating back exactly what you heard. It gives the person that requested the information that opportunity to hear it back, to make sure that they requested it correctly, and to also make sure that you have a shared mental model about what the request was. And finally, to close that loop, we're going to do the check back. So the check back is really now saying that either the task was complete, or maybe sometimes more importantly, you are unable to complete the task. This really is closing that loop of communication. And I'm going to just talk about in our system now kind of where closed loop communication broke down. This is Mackenzie Bryant. She was a heart transplant recipient when she was an infant. And at 4 years old, she was doing really well, and at 4 years old, she got a cold. And when her mom, Elaine Bryant, called her cardiologist, and she got a hold of the fellow, who then called the cardiologist and said, "What can I tell the mom?" And the cardiologist said, "You can tell her she can take this, not Afrin." And the fellow didn't repeat back and just said, "Okay," or something of that nature, and hung up and called the mom back and said, "You can give her this, and Afrin." That the mom gave Mackenzie Afrin in the car, and I wish we could play the video on the webinar, but you might be able to look for it online. The mom gave it to Mackenzie, and she arrested in the car on her way home from the pharmacy. She had to pull over, try to do chest compressions on a heart transplanted 4-year-old, called 911. Mackenzie was severely impacted, obviously, her health. She couldn't do anything on her own. There was a lawsuit about the cause of it, and ultimately UW paid $15 million, I think, the largest in our record, to the Bryant family, which doesn't do anything for them beyond. This is super impactful in our organization. It's the reason that Ross is in the role that he is. We have a full-time person helping us doing team training throughout our organization. You can see in the next slide, if you can go. This is from the Seattle Times, so it's still incomprehensible to her, that's Elaine Bryant, that such a seemingly minor thing, a brief miscommunication between two doctors, could have such a disastrous impact. And ironically, the University of Washington has been a pioneer in recognizing that communication is the cornerstone of patient safety. And we really did fail in our duty to communicate with each other. And we have to keep up the training for the closed-loop style of communication. And one of the things that we just like to emphasize during this time when we're talking about this extremely delicate and emotional situation is that we can't just do it when we think that it's important, because you never know when it's going to be important. So we have to practice that closed-loop style of communication all of the time so that it becomes ingrained in what we're doing. And so when there is important times, it will happen, will be guaranteed to happen because we've practiced it. So we do a lot of exercises throughout our training to make sure that we're practicing that closed-loop communication. The next tool I want to talk about is SBAR. So SBAR really is a framework to communicate. Could be about a patient's condition. It can be about a lot of things. I think this is one of the kind of universal tools within TeamSTEPPS that can be used, and I think Chris and Jen will talk about it later on, how it's used in non-clinical ways on an upcoming webinar. But we're going to talk about how we do it for a patient condition. So we always start with an introduction, especially when it's a phone encounter and people may not know who you are or where you're from, or an email in some instances. So here's the situation. Minty, a 58-year-old female with a history of AFib and hypertension, arrives to the clinic, the Echo Lab, as a new patient. She's been living in Spokane until recently and has been inconsistent, according to her daughter, with compliance with her meds and attending her appointments. So her daughter has recently had her move in with her in West Seattle. Minty's daughter, who serves as her mom's interpreter, tells the front desk person that Minty has been lethargic and has had a cough for 3 days. The MA finishes rooming the patient and takes admit vitals, which are, you can read the vitals. The mom appears to be having some difficulty breathing. Her daughter is concerned because she thinks her mom is not taking her meds consistently. She also has 3 children, which will make it hard for her to care for her mom. So that's a lot of information, kind of all kind of discombobulated that now we have to pull out that information to really make it concise and go back to that brief, concise, timely information. This is a great tool to do that. So for the situation, here's an example of what we could pull out from that. The situation is a 50-year-old woman has arrived hypertensive, is lethargic, has a cough, and is short of breath. And we really encourage people to say the situation is, use the words, because it helps not only the person giving the SBAR to kind of remember to be concise and talk about that information in that particular order, but it also helps the listener really pick up on those words and tune into what they're saying. The background. So in this case, we're going to give an example of the background is a new patient moved here from Spokane with history of AFib and hypertension, has been inconsistent with taking meds and attending appointments, doesn't speak English, and daughter is interpreting. The assessment. The assessment is her blood pressure is 178/98, stats are 88%, she's lethargic, her heart rate's 122, and it's irregular. That's an assessment. It doesn't have to be a diagnosis. This is where a lot of people get a little bit hesitant, is the difference between a diagnosis and assessment. You can just give what you know, and that's the assessment in this case. And finally, the recommendation. The recommendation is, I think she needs to be seen right away, and we might want to consider sending her to the ED. Same with the recommendation. I think it's sometimes hard for people in different situations depending on their role, but a recommendation can be as simple as somebody needs to come see this patient. We also talk about, in the courses we teach, about the recommendation in those really urgent situations, the recommendation coming in the beginning after the introduction, making the recommendation first. If you need that person to start moving now, if it's urgent, you might say, I need you to come see a patient at the beginning and then go into your situation background assessment instead of waiting till the end, but then repeat it in the end as well. So handoff. A handoff is the transfer of information during transitions in care across the continuum, and it includes the opportunity to ask questions, clarify, and confirm, which I think is sometimes a more difficult thing to do, is really giving that opportunity when we're handing information off, to give that opportunity for people to ask questions. Okay, I pass a baton is one way to do that. We think this is kind of difficult. This is in the TeamSTEPPS materials, but we have a hard time remembering this long of an acronym and what it all stands for. A lot of our areas use SBAR for handoff. So SBAR can definitely be a tool for handoff, and there are some others that I'll talk about as well. Anticipate, also, we don't use this one, but it's also a little bit shorter, so that might work. IPASS, which is by Boston Children's Hospital, was done by Boston Children's Hospital, and it is copyrighted, but you can go on and Google, and they will give it to you. I think you just have to register. They started this with their residency programs, and our residency programs here at UW-Medicine are now using it, and it's kind of spreading a little bit. So the two handoff tools that we mostly use here are IPASS and SBAR in different areas. So those are the two things.
Just one thing on that IPASS tool as well is they did a 9-hospital study. It's mostly children's. It was all children's hospitals for the study, and they found a 23% reduction in error due to handoffs when they implemented this tool. So if you're not familiar with it, we would encourage you to take a look at it.
Yeah. And, you know, when you think about how often handoffs are done, that's when a lot of the miscommunications and communication errors occur. So how important to have some standardized way. We're not advocating for any one tool, because you can also see there's the SHARC tool. However, having a standardized approach is best practice when you're doing handoffs, because then everybody knows what to expect, everybody knows what to look for and what information is going to be passed, and there's more likelihood of there not being a miscommunication or information left out. And I'm going to go ahead and turn it over to Megan to talk about situation monitoring.
Yeah, so as we're talking about sharing information, both handing off patients as well as just communicating amongst team members, getting to that state of an expert team, really what we're trying to get to here is an idea of situation monitoring, making sure that mistakes and oversights are caught, that there's processes in place for making sure everybody's on the same page. And so when we're talking about situation monitoring, it's really that state of knowing and understanding what conditions are currently present that affect one's own work as well as their environment and their team members. Some of the tools addressed in by TeamSTEPPS include cross-monitoring, which is really essentially just watching each other's backs, making sure that mistakes, oversights are caught in a timely manner so they don't make their way to the patient, as well as the STEP checklist and the I'm Safe checklist. And the I'm Safe checklist we'll talk about a little bit. It's kind of a checklist within a checklist, but first we're going to start with the STEP mnemonic. And so the STEP mnemonic, or the STEP checklist, is really just 4 key things to think of when we're thinking of maintaining situation monitoring. And really the STEP, S stands for status of the patient, T is for team members, E is for environment, and P is for progress towards goal. So if you think of these 4 criteria, it's really addressing that entire environment. So starting with the S, the status of the patient. These are things like making sure the team is aware, both you yourself as well as your teams are aware of things like the history of the patient, what are the current vital signs, medications, physical exams, what's the plan of care, how are we progressing towards that, and any psychosocial conditions that the team needs to be aware of. This is something that is pretty effectively done through an SBAR, and so something that we may want to consider using an SBAR to get to this STEP mnemonic. Moving on to T, it's important too to recognize what's going on with your team. So not only just what's happening in the team management of the patient, but the team members themselves. Are we considering things like fatigue, workload, people being distracted or overloaded with work? Task performance, does everybody have the skills that they need to perform the duties, or are we asking somebody who maybe doesn't have that skill and we should be moving them elsewhere in the team or giving them other tasks to perform? As well as stress levels. I think workload and a lot of initiative fatigue really compacts that stress level and our ability to effectively keep in mind what's going on with the team and with the patient. So making sure to address that in a timely manner as well. For E, the I'm Safe checklist, which is a way to address the team status of the team members and what they're doing. It's I'm Safe, addressing illness, medication, stress, alcohol and drugs, fatigue, eating and elimination. Now this is something that you could do individually, making sure that all of these things are addressed or accounted for in your own work, but also as a supervisor or manager or even team member, recognizing when these things may be factors in your team members and helping to address that or maybe help offload some of those things as necessary. Moving to environment, really looking at, do we have the resources we need to complete what we're trying to do? Do we have all the facility information, all the administrative information? Do we have the people on the team that we need, the human resources? Triaging and equipment. Oftentimes we find that some problems may be solved by just looking at the equipment availability and making sure that things are there. Easier said than done, and I know it's not something that's going to solve all problems, but being aware of what's going on in our environment really can affect our ability to progress towards our goal. Which brings us to the final part of the mnemonic, the progression towards goal. This is a prime opportunity to call a huddle if and when things are kind of going off track. Recognizing, again, what's happening with the patient. Are things moving in the direction that we anticipate them to? And if not, how do we get back on track? Recognizing what is the goal of the team and making sure everybody's working towards that same goal. Everybody understands that's what we're trying to get to. As well as maybe redefining tasks or actions that either haven't been completed yet or can't be completed for some reason, and making sure the plan is still appropriate. So keep in mind the STEP mnemonic as you kind of work in team settings especially, just as a quick reminder of a status check of what's going on. So real quickly, I want to have people take a second. What was the first thing you saw when this image popped up? And hopefully everybody can see it for shared mental model. Give folks a second to type into that chat box. get birds, birds, dogs, birds, birds, dogs, dogs, dogs. So just recognizing there are kind of two ways to view this image. Hopefully by now, people that see the dog may also be able to see the bird, and people that see the bird may also be able to see the dog. Hopefully we tried to pick the simplest one that we could find in hopes that we could kind of describe it over online. So one of the reasons we show this is that it's a great example of something that just at first glance, two people in a situation or even three people in a team may see something differently. So think back to the example that TeamSTEPPS has used for years, that duck and that rabbit. And if you're unfamiliar with the duck and the rabbit, we can share that image as well. But really what it is recognizing that how you ultimately perceive something may not be the same way that your team members perceive something. So what we want to get to is this idea of a shared mental model. And shared mental model is just basically that you're all reading off the same sheet of music, that everybody's on the same page, understands what we're trying to get to. And where this comes into play in patient care is if Ross and I, for example, are working with a patient. We run into the room and we see that this patient is a dog in this example. And we're working towards helping this dog, and then all of a sudden Ross sees something that shifts his understanding of the situation. All of a sudden this becomes a bird for him. And then it's really recognizing how we need to communicate as a team, because if he all of a sudden switches his what he's doing to work on a bird and I'm still working on a dog, it's going to be very different outcomes. We're going down two very separate paths. And so bringing it back to that shared mental model, or that idea that everybody's working on the same page and has the same understanding, it stems back to communication. How are we effectively communicating that as a team together? And so how do we get to that shared mental model? Using things like closed-loop communication, that call out, cross-check, check back, using SBAR as a way to bring the initial information forth, what's going on with the patient, what needs to be done, what are the recommendations. And prime opportunities to do this are the three kind of leadership tools that we talk about in TeamSTEPPS: briefs, huddles, debriefs, and transition and care. So we talk about briefs, huddles, and debriefs. It's really, we like to tell people to think of this as happening at the beginning, middle, and end of a situation. Those briefs are those planning sessions that happen right at the beginning. It's assigning roles, establishing expectations, our ability to anticipate outcomes, making sure we have the resources that we need. And then as you're progressing and things maybe are on track or maybe aren't on track, more importantly, when they're not on track or things are kind of going awry, that's a prime opportunity to call a huddle. It's that ad hoc planning session to reestablish or reinforce what the plan is and how we're working towards that. Following the action, the debrief, it's that information exchange. And I think for the most part, a lot of us are very familiar with briefs and debriefs. Huddles is a little bit more challenging, and one of the reasons why huddles and debriefs are 200-level skills in our mind is because they require practice. It's often difficult to kind of stop in the middle of an action and say, hey, everybody, we need to regroup. A lot of people say we don't have time to do that. Well, we would argue that you don't have time not to do that, because if you think about it, following a huddle, reestablishing the plan, or maybe reassigning people to different roles to better meet your goals in mind, then your actions are so much more effective, and you kind of make up for the time that was essentially lost to the huddle. One of the reasons, or one of the things that we try to remind people too, is using the terms. We like to use briefs, huddles, and debriefs as they're called. We understand that a lot of organizations may call what we call a brief a huddle, like have a morning huddle. One of the things that we would recommend is that if whatever terminology you come up with, make sure it's consistent across your organization, because essentially what we're trying to get here is that when we want to call a brief, we want people to understand what information they're going to get out of that action. When we call a huddle, understanding that this is something that we need to stop action, and it's a prime opportunity to kind of regroup as a team. So using those terms, and if those are not the terms you use, you want to come up with something else, that's okay. Just making sure that it's consistent and widespread across your organization, that everybody's on the same page. Otherwise, you lose that situational awareness or shared mental model of what's actually happening. So with that, I'm going to hand it over to Ross, who's going to talk a little bit about information exchange.
All right, so we're going to wrap this, get towards the end of this, and then leave some time for questions and answer some of the questions that people have been chatting in there. But the last part of this is dealing with some conflict in teams. And if your organization's anything like ours, we do have conflict once in a while. And TeamSTEPPS addresses two avenues of conflict. One is the informational conflict. It's just that you and I are not necessarily on the same page on what needs to be done with this patient. And then the other one is the interpersonal conflict. And that's you and I just are having trouble getting along at the moment, or having a personal conflict versus an informational conflict. And TeamSTEPPS addresses both of these. I can tell you the goal here is to prevent that informational conflict from turning into personal conflict. So we're going to briefly talk about CUS, and we're going to talk about very briefly about the DESC script, but I want to focus on CUS. And there is the other tool of two-challenge rule. We're going to start with the DESC script real quick, and this is dealing for that personal conflict. It's just an approach to try to minimize the personal attacks on each other when you're addressing this personal conflict. So it can be used somewhat in the moment, but you also have to be careful on choosing the right time for this. So it stands for describe, express, suggest, and consequences. And I'll just give you a quick example in our system. We had implemented, there was one of our departments that had implemented briefs, huddles, and debriefs for their rounds on a daily basis. And it was going really well, and people really thought it made rounds more efficient. Everybody knew what to expect. It was working out great. And then at the debrief, they were making changes based on what they were learning every day. And it was run by the attending physician. Or the attending physician was part of the debrief. It was actually run by the charge nurse. And one day at the end of the rounds, the attending physician just brusquely said, I got to get back to the OR. I don't have time for that. And people were kind of upset about that because they felt like it was providing a lot of value, and this physician didn't respond very well. And to this physician's credit and defense, she was a very strong supporter of the TeamSTEPPS implementation, and still is 5 years later or 6 years later now. But so they tried the DESC script with her, and the charge nurse went to her and said, you know, I noticed that you said you couldn't be at the round or at the debrief for rounds today. I'm concerned without you being there that we lose a little bit of our input on how we're going to get through this, and also we're compromising the credibility of the TeamSTEPPS implementation. I would hope in the future, if you're not able to make it to round or to the debrief at the end of rounds, maybe you can tell us that at the beginning during the brief so we're all aware of it. Because the consequences, if it doesn't occur, is I think we're going to lose our momentum with TeamSTEPPS. So at no time did I attack her on her, you know, become angry with her. I was very objective on saying how this affected the whole process of implementing the briefs, huddles, and debriefs on rounds, and it worked. I mean, she realized, she goes, oh yeah, I see what you said, what you mean, and in the future I'll do that. But and then she actually the next day, if I can't be in rounds, I'll announce it, and then if there's something I need to follow up, just let me know. So it's a hard tool to learn, and you have to practice it. It's hard to just shoot from the hip on that one. Now I want to get into what I think is probably one of the best tools there is out there, and that's CUS. I'm concerned, I'm uncomfortable, this is a safety issue. Now, I'm going to start getting back into the 100, 200, and 300 level skills because I think CUS, remember, was a 300 level skill. This is a culture change skill and a tool. And if anybody's been around long enough, they might remember when TeamSTEPPS first hit hospitals. This was back in like 2005, right around there. Every hospital in the world thought if we implemented SBAR and CUS, everything would be fine. And that 100,000 lives, or the IOM report, that would be fixed by just teaching every single nurse SBAR and CUS. Well, if you were around, you might remember it was a colossal failure. First of all, the only people that got taught were nurses. They didn't do this training for anybody else. And so as we look at CUS in our system, we think you have to have some foundation in place to really make this an effective tool. So let me describe the tool a little bit more, and then we'll get back into that. How do we implement this in our system? So I'm concerned. I walk into a room, and a patient's not doing very well, and there's somebody working with her airway. If anybody's ever seen just a routine operation video, this is a classic example where CUS would have been great. Hey, doctor, I'm concerned about Mrs. Bromley's airway. I'm uncomfortable that her saturations are dropping quickly, and if we don't stop, reoxygenate, and regroup or huddle, this is going to become a safety issue. Again, why I like this tool so much, why we like this tool so much, is it totally depersonalizes the conversation. I am not challenging somebody's ability to take care of that patient's airway. I am not getting angry. I'm not making them defensive. And we don't mean to go in and make people defensive, but we've seen it all happen. This starts opening the lines of communication. I'm concerned. I'm uncomfortable. I think this is a safety issue. So the key to this tool is it can't be used lightly. You can't cuss in every single thing that you see. It has to be really put in those patient safety issues that you want to address immediately. So again, we think this is a powerful tool. But as we systematically roll out these 100-level, 200-level, 300-level skills, we often work with groups that say, you know, we have to get to CUS right now. We like to introduce the 100-level skills because, like we said, you can do that training and you can walk out of the room and people should be able to do it 100% of the time. It's not because they don't know how to do it. They just maybe choose. And we used to say this is not rocket science, but changing behavior is rocket science, and that's what we're doing. So we try to systematically work through these tools. The first 5 are given. For SBAR, what you'll see us do to really ingrain it in people is that example that Farah showed you. We do simulations, SBAR simulations, where we use, depending on the group we work with, we customize a long, drawn-out PowerPoint, one slide, and then we ask them to make it into an SBAR. And so they practice that. Again, it's a tool that needs to be practiced. But those groups we work with that say, we really want to do CUS right now because we have some real issues and we have to address those now, we'll say, okay, let's do that. But you have to implement a brief too. And the brief is a great time to start to change the culture in the unit. One of our departments here in UW Medicine, in our OR, they implemented a brief for every OR in every room at 7 a.m. in the morning to discuss the whole room, to plan for the whole day in that room. Trauma center, level 1 trauma center, 27 ORs. And they have found that it's changed the culture in that OR the whole day. People feel more comfortable speaking up because they start with the circulator, the surge tech, the surgeon, and the anesthesiologist discussing what's going to go on for that whole day in that OR. And it's just changed the culture. So using the brief to start to change the culture is a classic example. At the end of the brief, I mean, every administrator in the world is going to say, yeah, I want people to feel comfortable speaking up, and that's great, but you really have to start empowering people. And if you have a brief and somebody in that brief that's running it, maybe the surgeon or the charge nurse or whoever it is, says, and if anybody has any concern, at the end of the brief, if anybody has any concerns about something going on with the patient, I want you to cuss at me. Kind of lightens the mood, but at the same time it empowers people to speak up. This, again, 300-level tool, CUS's 300-level tool, because it's just because you give somebody 3 words doesn't mean it's going to be easy to do. So using the brief to do that. Now, as we roll through these skills, we do a lot of our trainings for staff are only 90 minutes. And Farah mentioned this, we make people practice the tools. So in 90 minutes, we actually run through not all these tools, but we have some key tools that we think are you can make an impact on your staff very quickly and make it easier to sustain. We do all the 100-level skills, we do huddle, we do debrief, we do shared mental model, and then we go into CUS and 2 challenge. Those are our big impact tools when we only have 90 minutes to address TeamSTEPPS training with groups. In addition, we also have 3 simulations during that time. In our case, if you've ever seen us do our Lego exercise, we do that 3 times in that 90 minutes to reinforce the use of the tools throughout. You can do, there's the paper chain option. There's plenty of interactive exercises. You don't want an icebreaker. You want something where they actually have to break the tool or practice the tools. So we've had real good success in that. And then sustaining this process throughout, a big part of that, again, is starting small and working through these tools in a systematic way versus saying, okay, we're going to do a 4-hour training, here's all the TeamSTEPPS tools, or an 8-hour training, here's all the TeamSTEPPS tools, and not really have a set plan when you walk out of the room. So we put ownership on people at the end of those sessions, whether it's 90 minutes or 4 hours or however long we get, we put ownership on them. We will ask them to own, literally own, closed-loop communication, every one of those tools. Start using SBAR. We have them develop a plan for implementing briefs. How are they going to do debriefs? And if CUS is one of those tools, which often it is, then we insist that they do a brief too, because that's where they're going to get the most success. So, you know, again, here's just the list of the tools and some of the strategies and the barriers. I think we're all familiar with the barriers. We're really good at identifying those. The goal here is to move forward. So some resources on some of the things we talked about during our presentation. And here's how you can reach us, any one of us. We all sit about 3 feet from each other, so if you email one of us, you get all of us. So with that, I'd like to open it up to any questions that we haven't addressed. Oh, I'm sorry. I did want to address the infection control one from, I think her name was Leah, earlier on. And we have used TeamSTEPPS tools pretty significant in our infection control program. In fact, our IC people are master trainers in TeamSTEPPS. And some of the things that we've done is incorporated the patients and their families into things as simple as using CUS for hand washing. If they see somebody walk into the room and they didn't actually see them wash their hands, we've asked them to use CUS, and we do in-services for the patients and families, give them a little tiny hand gel, and let them practice using the hand gel, and then go through CUS. And so, and with all the staff knowing what CUS is, if a patient or a family member just says, hey, I'm concerned that I didn't see you wash your hands, I'm uncomfortable because my mom's a burn patient here, and this could become a safety issue for infection. Now we've started opening it up that way. They use it a lot in all of our central line placements. We do simulations interprofessional for that, and we actually throw in things like the person putting the central line contaminates their glove, and so the person assisting has to either do a 2 challenge or a CUS. So we have all kinds of ways we incorporate that into our IC program, and you can be really imaginative on that. Again, you don't want to take every single tool in the toolbox and throw it into your IC program, because then nothing's going to happen. Pick a few tools and move forward from there, and that's how we function with all of our implementation programs. Okay, sorry, now I'm done now.
That's okay.
Farrah or Megan.
Ross, we got a question about how do we address kind of power hierarchy and power differences amongst team members. Do you want to talk a little bit about that?
Yeah, and I think that's a great question, and it's very difficult. And again, that gets into why we think CUS and 2 challenge and DESC grip are 300 level skills, because you have to address the hierarchy thing too. And that's where the briefs come in. And during the brief, if you have, and people have to attend the brief, which means you have to provide value. And I know there was a question pre-webinar about how do you engage people that aren't, you know, the frontline staff? How do you engage physicians? And we see that too. How do we engage physicians and other groups that aren't necessarily under the same thing as nursing and MAs and whatnot? The way we engage them is you have to provide value. And so if you develop a brief, the brief has to provide value to everybody, not just nurse and the MA, and you just want the physician or the pharmacist there because you want everybody there. You have to come up, and it has to be owned by those people doing the brief. It can't be a top-down thing. We've had huge success with our briefs. Everywhere we've gone, everywhere we've worked with in our system, when they've implemented the briefs, their culture starts to change, and that starts breaking down that hierarchy where, especially if the surgeon is leading, that's the OR example, the surgeon is leading the brief, and at the end he or she says, if you have any concerns about something that's going on today with, and you know, they all say it a little differently, but if you have any concerns, I want you to make sure you speak up. So now they've empowered the people directly versus some policy that says we want everybody to speak up. So that's the way you start removing it. You know, and there's a little debate, and I push back on, in our system, we like to call everybody by their first names. And so if you start getting into that mode where people call each other by their first names versus Nurse Ross or Dr. So-and-so or Farm, whatever it is, that starts to break down the hierarchy too. That's a whole nother culture change, so, and a whole nother webinar probably. So.
Another question we received was about how do you implement or start to implement TeamSTEPPS in organizations or institutions where there's not a centrally located office to kind of help coordinate efforts. And it was a little bit higher up on the chat, so I'm not sure if I'm repeating that verbatim. But I think one of the things that we've run into are just our program itself, the WISH program, we're separated across many, many sites and trying to coordinate between different staff members, and it's something that we find very challenging. I would say focusing on closed-loop communication, the briefs, huddles, debriefs have been very effective for us, and kind of everybody needed kind of some onboarding or training to the initial tools, but once people start to see the value in how this can be used, even when there's not somebody kind of directing the brief, people will call for a brief themselves. Hey guys, can we have a quick huddle about this upcoming webinar, or can we have a quick huddle about this issue that we're having with a faculty member or a patient or a student that wants to get in with our Sim Center. I would imagine Chris and Jen in the webinar next month will talk a little bit about that, how it can be used in non-clinical settings as well. But I would say for the most part, focusing on those 100 and 200 level skills will be very effective tools in groups that are not co-located together.
Mm-hmm. And I think one of the other questions was more about how it is with patients, and Jen answered that they are going to talk about that in next month's webinar, get more details about how to use TeamSTEPPS with patients. Another question was, I think, was about do we use the SOAP format for when communicating with physicians? I'm not sure what that is.
No, yeah, no, we don't use SOAP. Although sometimes when you introduce SBAR, they'll go, well, that's similar to SOAP, and that's true. But we don't do that anymore. And in fact, we use SBAR now on telephone encounters in our clinics and whatnot. So that's a big one. Another thing I wanted to address too, kind of follow up with what Megan said, is the key is to get a few people in your system, whether they're to address like off-site people, but also there was a pre-webinar question on, you know, I'm interested in training, but how do I can't get anybody else really interested. I think the key is to get some master trainers on board, and that's the 2-day courses that Chris was talking about right at the beginning of this webinar. And you can go online and look where the courses are. We'd love to have you join us here. We're doing one in April. But the key is you first of all, you get some people that become experts at TeamSTEPPS, and then you go back and you realize this is not an additional initiative. This is integrated into what you already do. And so that's the key. That's how you get people to realize that this is not an additional initiative. You know, you're doing all these other things. Well, TeamSTEPPS is just integrated into what's already being done. So, and I think we're about out of time.
All right.
Yes.
So with that, turn to you, Chris.
Well, I was just going to thank you guys. We are out of time, but thank you very much for the great presentation, and thank you for sharing all that you're doing and then different ways that you're doing to think about this. Let's thank everybody for attending today and for chatting and questions throughout. If there's anything that we didn't answer, or some questions that were sent to us before the webinar that we didn't answer, we'll make sure to get those answered and get back to you so that you have some knowledge about what you wanted to know about. So other than that, I think we are good. Thank you all for attending, and hopefully we have you all online in February for the webinar about non-clinical uses of TeamSTEPPS.
Thanks, everyone.
Thank you.
Thank you, ladies and gentlemen. This concludes today's presentation. You may now disconnect.